Thanks very much, Lydia, and a warm welcome to all of my colleagues in CES-PHN. You're in for a very enjoyable night tonight, I'm sure, and a very informative one as well. We have two excellent speakers whom I will introduce to you as they come up to speak. And as Lydia has said, we have two topics for this evening. One is testosterone deficiency, to treat or not to treat, and the other one is an update on thyroid and parathyroid disease from the surgical point of view. So, without any further ado, I'd like to introduce our first speaker, Dr. Ash Gadja. Ash is a staff specialist in endocrinology at RPA and Bankstown Hospitals. He's a senior conjoint lecturer with the University of New South Wales. Ash actually has a special clinical interest in thyroid disorders, including antenatal management, thyroid cancer and thyroid orbitopathy. But tonight his presentation will be on androgen deficiency. So over to you, Ash.
Oh, great. Thanks, Peter. We'll jump straight into the talk, and we should have some time at the end for some questions. I've got a couple of cases to go through as well. So the definition of hypogonadism, it is defined as a clinical syndrome that results from failure of the testes to produce physiological levels of testosterone and the normal number of spermatozoa. And this is due to a disruption of one or more levels of the hypothalamic pituitary gonadal axis. There are a number of clinical manifestations of hypogonadism. We can think of it in three categories: physical, psychological, and sexual. From a physical standpoint, testosterone deficiency can result in a reduction in bone mineral density. It can result in reduced muscle mass and strength, gynecomastia. Anemia is an important one to keep in mind. Increased body fat and body mass index, and fatigue. From a psychological perspective, reduced mood, diminished energy, sense of vitality or well-being, and some effect potentially on cognition and memory. And from a sexual function perspective, diminished libido seems to be the most specific symptom, probably more important than reduced potency and performance. So testosterone laboratory measurements, it's useful to keep in mind that they can be affected by a number of factors. So in particular, the number of times we need to always reiterate in our letters and also with our training registrars that you cannot interpret a testosterone level without a concurrent SHBG level. The SHBG is affected by a number of factors. It can be elevated in the context of increasing age, hyperthyroidism, and if there's exogenous exposure to estrogens. And it can also be reduced by increased weight, insulin resistance, diabetes, metabolic syndrome, individuals on glucocorticoid therapy, sleep apnea, hypothyroidism, exogenous androgens, including testosterone derivatives or androgen precursors, and growth hormone excess, acromegaly. Testosterone measurements can be affected by time of collection, so it's best to measure testosterone first thing in the morning before 9 o'clock, and it can also be affected by food. From a time of collection point of view, it's useful to keep in mind that testosterone levels can drop 30 to 40% as the day progresses. So testosterone should be measured prior to 9 a.m. and fasted for at least 6 hours, and along with an SHBG. So this is probably the busiest slide of the talk, just summarizing acquired causes of hypogonadism. It's best to separate causes into central, which are secondary, or testicular, which is also called primary. So just focusing on central or secondary, this is defined as a low or low normal LH and or FSH in the context of a low testosterone. The commonest cause, and with increasing prevalence just at the bottom of the screen there, I've made a note, is in fact opioid associated and also withdrawal hypogonadism following androgenic anabolic steroid use. Mechanistically, the commonest cause being functional is due to GnRH pulse generator defect. We see that in the context of critical illness, stress, significant weight loss, anorexia nervosa, even undiagnosed and untreated sleep apnea. Mechanistically is thought to be due to an effect through the GnRH pulse generator. Narcotics, opiates, morphine equivalent dose of 40 milligrams or more, marijuana can suppress the hypothalamic pituitary axis. high-dose oral glucocorticoid treatment for a number of weeks, and even joint injections of steroid, and also supplements, prohormones, and anabolic steroids. Typically, these men will have an undetectable LH and/or FSH on testing. Along the lines of secondary causes of hypogonadism, the established but more structural causes, pituitary, in particular hyperprolactinemia due to a prolactinoma or causative medications, which in turn suppresses LH and FSH and results in hypogonadism. Tumor and mass effect from a macroadenoma, a craniopharyngioma, Ratkes cleft cyst, or pituitary metastasis. Infiltrative disorders, iron overload states or histiocytosis, and also inflammatory pituitary disorders, autoimmune, so-called lymphocytic hypophysitis. And we are also seeing other drug-induced causes, in particular the CTLA-4 inhibitors, such as ipilimumab. From a primary testicular cause, though, this is defined as an elevated or high normal LH and/or FSH with a low testosterone. This is usually due to prior chemoirradiation, testicular surgery or infection, torsional trauma. Certainly iron overload states can be associated with primary hypogonadism and probably not acquired, more present from early on in life would be Klinefelter syndrome and/or undescended testes. Just to note, individuals who are on exogenous anabolic steroids, that the recovery of the hypothalamic pituitary gonadal axis generally requires time, with very weak data to show that recovery is any faster if we utilize drugs such as clomiphene or HCG. And in fact, if men get hold of these compounds, it might propagate their continued illegal use of anabolic steroids potentially. So just a note on sleep apnea and the resultant secondary hypogonadism. Hypoxia results in increased cortisol and catecholamines. This in turn results in central adiposity, insulin resistance, and hypertension. And the hypoxia results in reduced nitric oxide in cavernosal muscle with subsequent reduced potency. Untreated sleep apnea results in slight impairment in the GnRH pulse generator, and often these men make normal levels of testosterone or are capable of making normal levels of testosterone. And it's very important to keep in mind that testosterone therapy can in fact worsen untreated or undiagnosed sleep apnea. When do we need to image the pituitary? When we are faced with biochemistry indicating secondary or central hypogonadism. Survey studies of middle-aged and older men with sexual dysfunction and secondary hypogonadism in fact indicate a low prevalence of Sella lesion detection. There is an increased yield if you restrict imaging to men who have evidence of other pituitary hormone dysfunction, certainly if someone has hyperprolactinemia or a very low total testosterone below 5.2 nanomoles per litre, or has visual changes or headache. And in the context of a normal prolactin where someone has one of those other manifestations listed above, a CT scan of the pituitary is generally going to be sufficient, as the main indication for imaging is to exclude presence of macroadenoma. So MRI pituitary, certainly in the context of elevated prolactin, as most prolactinomas are micro, meaning under a centimetre, and certainly the detection would be more sensitive utilizing MRI rather than CT in that context. Obesity leads to low testosterone, and this graph demonstrates quite nicely that if we track age, there is a natural reduction in testosterone. So the blue line there depicting someone who has a BMI below 30, who then transitions towards having a BMI above 30, we can see that the rate of decline in testosterone with increasing age is faster and steeper if one carries more weight. And on the converse, we know that weight loss increases serum testosterone. So this is a lovely meta-analysis from a group in Melbourne where the open circles represent diet and exercise intervention. The grey circles represent men who have undergone bypass surgery, gastric bypass surgery. And we can see the extent of weight loss achieved with both of these sets of interventions, the size of the circle representing the sample size of those studies. And we can see generally if we aim for a 10-15% weight reduction, we can see about a 4 nanomole per litre increase in total testosterone. And for men who have had bariatric surgical interventions who are losing 25–30% of baseline body weight, we can sometimes see up to a 10 nanomole per litre increase in total testosterone levels. So calculated free testosterone is something that the laboratory can calculate for us, but it requires 3 parameters: total testosterone, SHBG, and albumin. And generally these 3 parameters are plugged into what's called a Vermeulen equation, and it will spit out a calculated free testosterone. Certainly calculated free testosterone is more reliable than a laboratory free testosterone, which unfortunately performs poorly. But what's interesting is data from, in this case, the European Male Aging Study. They found that obese men who have a low total testosterone along with a low calculated free testosterone, so that's factoring in the likelihood that these men have a low SHBG, are more likely to develop sexual symptoms of hypogonadism compared to men who have a low total testosterone but a normal calculated free testosterone. So in this particular context, what's happening is the SHBG is giving us a false low total testosterone, but when you do a calculation and in fact that man has a normal calculated free testosterone, if you track those men, they're probably less likely to develop sexual symptoms of hypogonadism. If we have the situation where we have a low calculated free testosterone with a normal total testosterone, these men, interestingly, are more likely to have a higher prevalence of symptoms of sexual dysfunction, lower hematocrit, and lower bone density, indicative that this may also be a group of men that we need to consider treatment for. So what are the potential risks of testosterone replacement therapy? This is from the Endocrine Society guidelines 2 years ago, a systematic review and meta-analysis indicating that the most frequent adverse event from TRT is erythrocytosis. There doesn't appear to be a significant change in lower urinary tract symptoms, particularly in men with an international prostate symptom score below 20 or 21, which indicates mild or moderate prostate symptoms. So I think a score above 20 indicates severe prostatic symptoms of lower urinary tract symptoms suggestive of BPH, etc. In terms of the literature review, TRT, there appears to be an increased risk of detection of subclinical prostate disease. Invariably, men are more likely to score themselves a prostate biopsy if there is a rise in PSA, even though it may not be of significance. Clinical trials are not large enough or long enough to evaluate the effects of TRT on major adverse cardiovascular endpoints or prostate cancer risk. So the conclusion from the Endocrine Society at present is that there is no clear evidence that TRT increases the risk of MACE or prostate cancer. There are, however, strong contraindications to offering TRT. Men with high-grade invasive or metastatic prostate cancer, invariably such patients are generally treated with androgen deprivation therapy. Men with breast cancer, decompensated cardiac failure, a significant baseline erythrocytosis with a hematocrit above 50%, and untreated severe sleep apnea. There are some controversial or relative contraindications to TRT. So we'll talk about a case in a moment. But if a man has a history of prostate cancer, if he is low risk, and particularly if the Gleason score is 6 or below, and if that man is deemed cure, TRT could be considered in a man with symptomatic hypogonadism, but this needs to be case by case and following urology approval. In men with a prior history of coronary artery disease or stroke, the current recommendations are not to initiate TRT in a man with symptomatic hypogonadism for 6 months post myocardial infarction or stroke. And we'll talk about men with a history of DVT in a moment. So the situation with TRT and VTE, or venous thromboembolism, is that we should probably consider evaluating for a clotting disorder only in men who have unexplained thrombosis whilst on testosterone therapy. So if we look at a number of studies here on the right, across all of those cohort of men, there was in fact no difference in relation to development of idiopathic venous thromboembolism in men offered testosterone therapy or not. The commonest underlying clotting disorder that can increase the risk of unexplained thrombosis while on TRT would be factor V Leiden. When we talk about TRT and bones, we know that testosterone therapy, so here on the right, this is looking at the testosterone trials in men over 65, indicating an improvement, even with Testogel, on volumetric bone mineral density as ascertained by CT BMD 12 months after TRT initiation at both spine and hip, with an improvement in bone strength. Guidelines on the left here are somewhat dated, but do indicate that if you have a man who is deemed high risk of fracture with a testosterone below 7 and there are contraindications to utilizing approved agents for osteoporosis, so our anti-resorptives, that we could consider testosterone therapy alone, and perhaps cautiously for men with borderline high risk of fracture with symptoms of hypogonadism with a total testosterone below 7 nanomoles per litre. So this concept of late onset hypogonadism, some nice studies done almost a decade ago now showing that testosterone levels below 8 nanomoles per litre seem to correlate best with symptoms of hypogonadism in an aging male. So with testosterone levels below 8 nanomoles per litre, there seems to be an upkick here in blue on decreased frequency of sexual thoughts. We are also seeing a trend from 8 to 8.5 with a greater report of erectile dysfunction, and probably from a testosterone level below 11, a reduction in frequency of morning erection. If we look at on the right side, their definition for late onset hypogonadism being 3 or more symptoms, sexual symptoms, including the 3 we've talked about, so reduced potency, reduced early morning erections and decreased sexual thoughts, that the overall prevalence of late onset hypogonadism is probably at most 3 to 5%. And we can see that the prevalence of LOH may in fact be somewhat skewed by concurrent comorbidities, namely obesity and other medical conditions. So those men who are slimmer, with less comorbidities seem to have a prevalence of LOH of approximately 1 to 2% versus up to 5% in men with a BMI of 30 and above, or with 2 or more chronic medical conditions. So this led the Endocrine Society to come up with a few recommendations on this topic, that we recommend against routine prescribing of testosterone therapy to all men 65 and older, with low testosterone concentrations. In men over 65, however, who have symptoms or conditions suggestive of testosterone deficiency, such as low libido or unexplained anemia, and consistently or unequivocally low morning testosterone concentrations, that we could offer TRT on an individualized basis. The evidence to date does support TRT in both middle and older age men in terms of improved sexual function, improvement in anemia, and as I've demonstrated, an improvement in volumetric bone density and strength over 12 months at both spine and hip. So there are a number of TRT formulations available to us, and this just summarizes the 3 more common modalities. So we have short-acting intramuscular injection, the brand names of Sustanon or Primotestin. This is typically administered as 250 milligrams every 2 or 3 weeks. However, when we look at the pharmacokinetics, we find that if we were able to give 100 milligrams weekly, as depicted here in the top left graph, that we would probably achieve most stable and physiological levels of testosterone for men on this treatment modality. In terms of monitoring testosterone levels, we would typically recommend a measurement of testosterone midway between injections. The advantages of the short-acting intramuscular injections, they're inexpensive. Men can learn to self-administer. The disadvantages, variable pharmacokinetics, you can see here in the graphs, depending upon the dose that's used and also the frequency of injection, that you do get lots of ups and downs, and men certainly feel this. you can get fluctuations consequently on mood and libido, and there's also potential concerns with pain at injection sites. More commonly, we typically use a slower acting depot preparations. This is testosterone undecanoate or Reandron 1000. This is a long-acting intramuscular injection, typically given above the gluteal muscle. Following the injection, we achieve much better physiological testosterone levels. Typically, an injection is given at time 0, repeated after 6 weeks, and thereafter, most men can get by with an injection every 10 to 12 or even 14 weeks. The injection does need to be administered slowly over a minute or so because it is made up in 4 mL of castor oil. In terms of monitoring testosterone levels, we typically monitor trough or pre-injection levels and we adjust dosing interval accordingly. We typically aim for a trough level or pre-injection level around that 10 to 13 nanomoles per litre. The advantages of Reandron 1000, you do get less fluctuation in testosterone levels compared to the short-acting intramuscular preparations, potentially less mood swings, and men can get by with 4 or 5 injections per year once stable. Disadvantages, there is this uncommon phenomenon called pulmonary oil microembolism or POEM. Men typically present with a non-productive cough within minutes post-injection. Incidence is 1.5%. Doesn't seem to matter whether it's given by a trained or non-trained health professional, but the recommendation is to inject Reandron slowly over the 60 to 90 seconds and ideally to observe the man for 30 minutes post-injection. And in terms of the gels, the available gels, Testogel 1% and Testovan 2%, these are typically applied to the shoulder or side of abdomen. The manufacturers of Testovan actually push for shoulder application rather than side of abdomen application. You can monitor testosterone at any time after 1 week of initiating treatment. The advantages of Testogel or Testovan is that it's convenient. It probably mimics circadian rhythm the best, and generally men have good skin tolerance. There is that disadvantage of potential for transfer to partner. Skin irritation may be in 5% of men, and you can get variable testosterone concentrations even though all other parameters are constant. It can drive us nuts doing total testosterone levels periodically and find that levels are up and down. What's interesting is they do report that there are some shower lotions that can affect absorption, and so it's useful to tell men who are on this type of formulation to use an unscented bar soap. So monitoring on TRT is to evaluate the patient at 3 to 12 months after treatment initiation and then annually to assess whether symptoms have responded to treatment and whether the patient is suffering any untoward effect from therapy. We monitor total testosterone concentrations 3 to 6 months after initiating testosterone therapy, and the aim is to raise serum testosterone into the mid-normal range. To check hematocrit at baseline and 3 to 6 months after starting treatment and then annually. To evaluate formulation-specific adverse events at each visit, and to measure bone mineral density of lumbar spine and or femoral neck after 1 to 2 years of testosterone therapy in men with osteoporosis. In terms of prostate monitoring, for those men who are at increased risk of prostate cancer or who choose prostate monitoring, to perform a baseline digital rectal exam and PSA before initiating treatment with follow-up 3 to 12 months after TRT initiation, and to obtain an urgent urological consultation if there is an increase in PSA of above 1.4 micrograms per litre within 12 months of initiating TRT, or a confirmed PSA above 4 at any time, detection of a prostatic abnormality on digital rectal exam, or if the man complains of substantial worsening of lower urinary tract symptoms. So we'll just go through a couple of cases and then happy to take some questions. So we have a 59-year-old male who presents with a 12-month history of reduced libido with an unsatisfied partner, who has a past history of radical prostatectomy 3 years ago for a Gleason score 7, 3+4. Total testosterone measurements of 3.5 and 4.5 nanomoles per litre, reference ranges are there in brackets, with an elevated LH of 30. The DEXA scan shows femoral neck T-score of -2.2, consistent with severe osteopenia, and the PSA is undetectable. So the question is, would we treat this man or not? Now, looking at the Gleason score, generally we'd feel more comfortable if we had a Gleason score of 6 and below. But my understanding is with a Gleason score of 3+4 as opposed to a 4+3, this person still has a relatively good prognosis from the prostate cancer perspective. We are now 3 years on from initial surgery, and the PSA is undetectable. So I think in this particular context, this gentleman clearly has primary hypogonadism. And if we have approval from the urologist, he's clearly symptomatic with a reduction in bone mineral density and would probably benefit from TRT. As part of the diagnostic workup, we may order iron studies, and I would probably also order a carrier type to exclude undiagnosed Klinefelter syndrome. Now, if we just put a spin on that same individual, what if he had an acute myocardial infarction 2 years ago and a left lower leg DVT 12 months ago following ankle surgery, and posed the same question, would we treat with testosterone or not? Well, I guess in this particular context, if his cardiac status is stable, we know that TRT is not advised within 6 months post myocardial infarction. But if his cardiac status is stable, and again, we've got clearance from his cardiologist, and certainly in relation to the DVT, there was a precipitant in the context of an ankle surgery. I don't think in that context we need to be measuring for a thrombophilia. But again, he has symptomatic hypogonadism, and I think these additional bits of information, once we get approval from cardiology, that there wouldn't be an absolute contraindication to offering TRT here. Case 2, we have a 59-year-old male, same presentation, 12 months of reduced libido. He has a past history of type 2 diabetes, hypertension, sleep apnea on treatment, with recent knee pain requiring a cortisone injection. He has a BMI of 33 and a total testosterone of 8.8 and 9.2, just slightly below the reference range or low normal, with an LH that's within reference range at 4 units per litre. Additional investigations, well, biochemically, this gentleman is showing signs of secondary hypogonadism, so we would need to check a few additional things. So as mentioned, SHBG is required with all total testosterone measurements, and in fact, this particular fellow has a normal calculated free testosterone. So we did say that according to data, if you have an obese male with a low total testosterone but a normal calculated free T, that generally speaking, these men are less likely to complain of symptoms long-term of hypogonadism, and there's usually some other reason as to why the total testosterone is low. And in this particular case, it's probably being driven low due to a low SHBG. He has a normal prolactin. We confirm that his OSA management is satisfactory. We check his iron studies and they are normal. And we checked his ACTH and cortisol because he did have a cortisone injection. And as I mentioned, high dose oral glucocorticoid therapy or even injectable steroid can temporarily suppress your hypothalamic pituitary axis. This is partly because the GnRH pulse generator has cortisol receptors that can be suppressed by exogenous steroids transiently. Because the prolactin was normal in the context of secondary hypogonadism, a CT pituitary was organized that was normal. MRI not done because we only need to exclude a macroadenoma in this clinical context. So would you offer this gentleman TRT? Probably not. I think his testosterone is reading low because of increased weight and or recent steroid exposure. I think the emphasis here with a BMI of 33 and other comorbidities that are probably related to weight and/or metabolic syndrome is to focus on a 10 to 15% weight reduction, and I'm sure the total testosterone will improve. And we also know that with weight reduction independent of improvement in total testosterone, that we would expect to see an improvement in sexual function. So I'm happy to stop there, Peter, and take some questions.
Well, thanks very much for a great run through there, Ash. Unless I'm looking at the wrong part of my screen, I don't think we actually have any questions from the audience, but maybe I could try to stimulate them by asking one or two myself. Could you fill me in on why, with the short-acting testosterone injections, you monitor halfway between, whereas with the longer-acting ones like the Reandron, you monitor trough levels?
Yeah, so let's just come back to the slides here. So the trough level is partly so that we've got a buffer. So with the long-acting Reandron, you know, we're expecting a quick rise over the few weeks post Reandron injection. It usually peaks around that 4-week mark, or 2 to 4 weeks after Reandron. So as we can see here, for example, I don't know if you can see my cursor, but we've got the lines representing normal physiological reference range. And we do want gentlemen to sort of drift down to the lower end of that physiological reference range before giving another booster injection. If we're giving a booster injection with a trough, you know, with a testosterone of 20 or whatever it might be, you know, invariably you're going to cross the upper limit of normal physiology. So for long-acting, we want the testosterone to drift down to the lower end of normal. And so around that 10, 12, 13 nanomoles per liter before we give a jab, and we would expect that, you know, over 4 to 8 weeks, that man will probably maintain testosterone levels, you know, around that 15, 20 nanomoles per liter. When it comes to short-acting, sort of midway in between is more partly because of the limitation of a pre-injection testosterone measurement in these men. You typically find that their pre-injection levels can drop off quite significantly, particularly if they're on the 2 or 3 weekly injection. I invariably will do a midway between injection as well as a trough, just to make sure that you know, the midway I'm not exceeding physiology, and in terms of the pre-injection, that guides me more in terms of altering the dosing interval between injections. Okay.
And Ash, one other question from myself. Should I be doing a serum testosterone on all of my osteoporotic men, or should I be reserved?
Absolutely. Yes. So that's part of the secondary osteoporosis screen in men. So, you know, when you look at causes of osteoporosis in men, 50% are idiopathic. The remaining 20-25% are probably hypogonadism, and the other one to always be aware of is steroid-induced osteoporosis in that male cohort. But testosterone deficiency is a must as part of the secondary osteoporosis screen in men.
Okay, Ash, thank you very much again for a great presentation. Thank you.
That's all right. Thank you.
We'll go on to the second part of our presentation for this evening. And that's a talk from Associate Professor Michael Elliott. Michael is an ENT head and neck surgeon who's currently appointed at Lifehouse at the Chris O'Brien Cancer Centre and the Royal Prince Alfred Hospital. He's a graduate of the University of Adelaide, and he undertook postgraduate studies at the University of Queensland and at Guy's Hospital in London. He chairs the Thyroid Cancer Multidisciplinary Team at RPA. And tonight he's going to talk to us on his main areas of interest, those being the management of thyroid and parathyroid disease. So, Michael, thank you for being with us tonight, and over to you.
Thanks so much for the introduction. Can I just check what you can see? So, can you see my screen yet?
Yes, Michael, we can see Michael.
Your... And it's full screen as well.
Better. Yeah, okay, that's good. Okay, all right, great. Okay, I'll just double checking. Okay, so what I thought I'd do is I'll just give a discussion on some of the more recent changes in the management of thyroid disease and give an update on how we're managing patients with parathyroid disease as well. So the basic outline is I'll give just a very, very quick brief slide on basic anatomy and epidemiology, and then we'll divide the talk into 3 areas, basically talking about thyroid nodules, hypothyroidism and hyperparathyroidism. And we'll cover the important aspects in respect to clinical assessment, what are the relevant investigations, and I'll give some guidance as to initial management and when to refer patients for further treatment. So just very, very quickly, just with respect to the basic anatomy, so the thyroid gland consists of a right lobe and a left lobe with a junction, with the isthmus between the two lobes. On the lateral view, where you've got the trachea and the esophagus, what's really important is for thyroid surgery are these little parathyroid glands. They look nice and easy to find in this picture, but I can tell you that that's never the case. There's the recurrent laryngeal nerve that sits very close to the thyroid gland, and that nerve is clearly the nerve that's most important to protect during thyroid surgery, so we don't have issues with voice change. So just with, oh, did I miss a slide? Okay, so I thought I'd just very quickly start with just a case example. So this is someone I recently saw. There's a young lady who presents with a right thyroid mass that has been present for 6 months. She thinks it's getting bigger. She hasn't had any discomfort associated with it. There hasn't been any change in her swelling or voice. She denies any compressive symptoms. She does not have a history of radiotherapy, and there's no family history of hypothyroidism or other. Sorry, there's a family history of hypothyroidism, but nothing else. So when you ask her to swallow, she's got this very obvious right thyroid nodule here. So ultrasound was performed, and that demonstrates that the right lobe measures 7 mils, so which is a normal size, and the left lobe is 4 mils. In the right lower pole, there's a 26 millimeter thyroid nodule and as much smaller adjacent 16 millimeter nodule. So if we look at the cross-sectional or transverse view, this is the trachea here, this is the right lobe, and this is the left lobe. Now, here's the nodule here, which has got a nice well-defined border. It's got what we call a spongiform appearance. So this is a fairly benign-looking nodules. There's no nodules on the left-hand side, and she doesn't have any abnormal cervical lymph nodes based on the ultrasound imaging. A needle biopsy has demonstrated Bethesda 2, which is benign, and I'll explain more about the Bethesda classification and how that's important in thyroid nodule assessment. She has a blood test that demonstrates that she's got normal thyroid function, so we're not dealing with a functioning nodule. So the question for this lady is how do we manage it? She's got a benign nodule. Now, for her, her main issue was the cosmetic concern, and I explained to her that essentially the nodule doesn't have any sinister features, and there's no necessity for surgery with respect to abnormal pathology or concern for cancer. But her main issue was with the cosmetic concern. So we discussed potential surgery to remove that, and she's thinking about whether she wants to go ahead and have that done. But so this is a fairly common presentation of a nodule, and this is something that we see in clinical practice very commonly. Just to have a look at a bit of the epidemiology of thyroid nodules, they're extremely common. If we look at the graph on here, so they're divided into non-palpable and palpable nodules, and around the age of between 60 and 70, about half females have got the presence of non-palpable thyroid nodules, about 35% of males, and the incidence of palpable thyroid nodules approaches 10% as you get up into your 70s and 75 years of age. I mean, that's highly dependent on the normal anatomy of the patient. So if you've got someone who's got a really big thick neck, it's almost impossible to fill thyroid nodules unless they're very, very large. The important thing about thyroid nodules is that the vast majority of them are benign. Okay, there's only a very small subset of nodules that are cancer, and even within that subset of nodules that are cancer, the vast majority of them are well differentiated, for which the chance of a patient dying is extremely low. So the challenge is with these patients that have got very, very common thyroid nodules is how do we assess those patients as the ones that have got indolent nodules that are not going to cause them any problems and can be left alone, and those that are potentially cancers, and when to intervene. So thyroid nodules can be solitary, or they can be part of a multinodular thyroid, so that's a thyroid that's of normal size, or part of a multinodular goiter, so it's an enlarged thyroid. The vast majority of them are simple colloid nodules or simple cysts. There's a much smaller 10 to 15% rate of the nodules being benign follicular adenomas or benign tumours, and only 5% of them will be thyroid cancers. And as I said, the vast majority of those will be well differentiated thyroid cancer. So what's the relevant clinical assessment with patients who present with thyroid nodules? The most important things that I ask patients with assessment for, oh, hang on, I've just lost my presentation. Sorry. Let's do this. So there's this box on the side that's in my road. Hang on, I'll try again. Okay. Oh, damn it. I'm trying to minimize that box on the side. It keeps closing down my, I just have to leave it, I think. So what are the most common symptoms that are associated with thyroid nodules? And these are the questions that are important to ask. So patients who present with compression or a choking sensation, so these are people who say that they can feel a lump when they swallow. Any swallowing or voice change is important, and certainly if there's any change in growth. Oh, this is so annoying. Hang on, sorry. Oh, there we go. And any cosmetic concerns is important to ask the patient about. A few of the nodules are associated with overproduction of thyroid hormone, so those patients will present with those classical symptoms of hypothyroidism or thyrotoxicosis. So the more important ones are things like nervousness, heat intolerance, palpitations, fatigue, and weight loss. And then asking about factors that will be red flags for potential thyroid cancer being present. So things such as the rapid growth in the size of the nodule, the extremes of age, so nodules in patients under the age of 20 or in the age over than 70. Nodules are much more common in females than males, so male sex is a risk factor. Previous radiation exposure, and that would be in the setting of patients who have had radiotherapy for head and neck lymphoma. Prior history of Hashimoto's thyroiditis does increase the risk. Certainly a positive family history, although that's pretty rare to see someone who's got a positive family history of thyroid cancer. With the important aspects of the examination, a close assessment of their voice. So any voice change is really important. So in the rooms, we perform nasal endoscopy. And so I just wanted to show you, this is the sort of view that we see of the vocal cords. This is actually a patient who's got papilloma. This is the sort of view that we get in the room, so we can see, you know, what's happening with the vocal cords, how they're moving, and you can have an assessment of the lower throat as well. Look for those clinical signs associated with hypothyroidism, and palpation of the neck and thyroid is best performed from behind. It's really dependent on the anatomy of the patient and whether the patient has got a nice thin neck or a very thick muscular neck. Taking note of the nature of the nodule. So certainly very firm nodules and certainly very fixed nodules are very worrying. For patients who have got enlarged thyroids, I like to know whether I can get below the thyroid. If I can't get below the thyroid, then I start thinking about retrosternal extension. Certainly any lymphadenopathy would be a red flag for potential metastatic thyroid cancer. Pemberton's sign. So this is a picture down the bottom. So when this gentleman raises his arms above his head, he gets flushing of his face, and that's due to venous obstruction from the thyroid at the thoracic inlet. This is a clinical photo of a patient with Graves' disease, and they've got that thyroid stare. You can see the increased sclera of the eye. The important investigations with assessing patients with thyroid nodule include thyroid function tests, because we need to know whether that patient has got hypothyroidism. So organising a TSH level, Thyroid autoantibodies are important in the setting of not only cancer, but also other conditions such as Hashimoto's. TSH receptor antibodies in the setting of hypothyroidism and a patient who potentially might have Graves' disease. The most useful radiological investigation for thyroid is ultrasound. It's far superior than CT or MRI scan. Most of the ultrasound machines these days are high resolution, and they're much less grainy than what they were in the past. The ultrasound can determine whether the nodule is cystic, solid, or a mixture of both components, can tell you whether there's one nodule or multi-nodules, can give an assessment on retrosternal extension, and is also critically important for looking at lymph nodes, because enlarged lymph nodes that have got abnormal morphology are a red flag. Lymph nodes that have normal morphology are generally reactive and reassuring. With respect to the thyroid nodule, the important parameters that are assessed are the size, hyperechoic, so that means whether it's dark compared to the normal thyroid, having a look at the margin of the thyroid nodule. If it's got a very irregular margin and an infiltrative pattern, then that's a red flag. Microcalcifications are the most worrying type of calcification that can occur in thyroid nodules, which is indicative of papillary thyroid cancer, hypervascularity, and nodules that are taller than wide. There's a classification called TRT, and I'll explain that shortly. That's a newer classification that's come out, which is really useful for people in assessing thyroid nodules, because it gives a risk assessment as to the abnormal nature of the thyroids and of the thyroid nodule, and will also guide in management in saying which ones need FNA and which ones can be safely left alone. So the thyroid classification looks at different factors, including the composition, the echogenicity, the shape, the margin, and whether there's any echogenic foci. And there's points that are allocated depending on whether these factors are present or not. And then from that, you get a total number of points, 0 to 3, 4 to 6, or greater than 7. And then there's a TR or a thyroid classification based on that. So if we look at a TR score of 1, thyroid score of 1, that's a very benign nodule with no indication for finding aspiration biopsy. A TR2 is one that is not suspicious, so therefore no final aspiration is indicated. With a TR3, there's some abnormalities that are demonstrated on the ultrasound. So the guidelines are start thinking about a needle biopsy if the nodule is greater than 2.5 centimeters, and also follow those nodules up. If we're getting a score points of TR4 to 6, we're starting to see a TIRADS 4. So this is a moderately suspicious. So I've got some examples in the next slide. So we're seeing the recommendations and the guidelines about needle biopsying of the nodules greater than 15 millimeters, and following them up if they're greater than 1 centimeter. And certainly if you've got more than 7 points, that's a highly suspicious TIRADS 5 nodule. And so the recommendation is needle biopsy down to 1 centimeter, and follow up if the nodule is 5 millimeters. So the important thing about the TIRADS classification is that this is a report that you're now kind of expected to get back from the practices that you're referring for your ultrasounds, and it just helps you work out whether the patient needs a biopsy or not. So it's a really important classification for guiding management. So these are just some ultrasound pictures. So this is essentially a right thyroid nodule. It's got a cystic nodule in here, little bits of debris in here, but this is a very safe TIRADS 1 nodule. It does not need a biopsy. With the TIRADS 2, this is a classic, what they describe a spongiform nodule. So it looks like a sponge. It's got a nice rim around it. It's got the classic kind of spongiform appearance, mixed cystic and solid components. Very safe. It does not need a biopsy. With a TIRADS 3, we're starting to see nodules that are becoming a little bit darker. This one here is sort of a lower suspicion because it's got a nice margin around it. It's not as dark as the TIRADS 4 one. So the TIRADS 4, we're starting to see that the nodule is quite dark compared to the normal thyroid. We're starting to see some irregularities, some little nodularity of the margins. So this is a moderately suspicious nodule. And certainly in a TRADS 5, this is a nodule that's got not only an irregular border, it's got the speckled appearance of microcalcification, and this would certainly be a highly suspicious nodule for papillary thyroid cancer. So you don't need to be able to look at the pictures and report the nodules. Essentially, if the radiologist has reported those nodules in a TRADS classification, then that really helps you in your assessment of how to manage that patient. The next change that occurred a little while ago was the FNA reporting. So FNA reporting used to be benign, non-diagnostic, suspicious, or cancer. And then because of the large number of patients who were getting surgery for indeterminate nodules, the Bethesda group developed a system that is based on a further distinction between the indeterminate groups as a lower risk and a higher risk. So Bethesda is now in 1 to 6. So a Bethesda 1 is non-diagnostic or unsatisfactory. You can't really make any assessment. So the aim in that patient is to repeat it, even though the risk of malignancy is low. So a Bethesda 2 is benign, very safe, leave it alone, clinical follow-up. A Bethesda 3, they're starting to see some cellular abnormalities. It's called an atypica of undetermined significance or Flicker lesion of undetermined significance, so the terminology that you might see reported. The risk of malignancy in those is 5 to 15%. So we would recommend, with discussion with the patient, a repeat fine-needle aspiration biopsy. When would you do that? I would generally repeat it somewhere between 3 to 6 months, certainly not before then. The reason why you don't do it before then is because you may have a lot of bleeding into the thyroid from the previous biopsy, and what you don't want is another needle biopsy that just demonstrates blood, and then you'll get a non-diagnostic FNA report. So generally repeating the needle biopsy in 3 to 6 months. Now the issue is that if you get 2 abnormal Bethesda 3s, your risk of malignancy goes up to about 30 to 40%. So they're the patients who we start talking about diagnostic surgery, because currently in Australia, we don't have a better test. There are genetic tests that are available overseas, but they're not part of routine clinical practice in Australia. So Bethesda 4 is described as a follicular neoplasm or suspicious for a follicular neoplasm. So these will be your follicular adenomas versus follicular carcinomas, which the needle biopsy cannot distinguish between a benign or a benign pathology or a cancer, because it cannot look at capsular invasion or invasion into blood vessels. The risk of malignancy approaches 30%. So those patients would then be referred for a diagnostic surgical lobectomy for further pathological assessment. A Bethesda 5 is suspicious for malignancy, and although it's reported between 60 and 75%, certainly locally at RPA, it's very rare to get a Bethesda 5 that's not actually a cancer. So the pathologists are very confident in Bethesda 5 that it is actually a cancer. In those patients, they require surgery, and the surgery will depend on a number of factors, whether they have a hemithyroidectomy or a total thyroidectomy. And having said that, there are a small subset of patients with very small tumours that we're now talking about active surveillance. So Bethesda 6 is malignant, so that's 100% risk of cancer. So even though the Bethesda guidelines are talking about surgery, that's really for tumours that are greater than a centimetre, or even now we're now talking about 15 millimetres. And we'll talk to the patient about whether they have active surveillance, heavy thyroidectomy, or total thyroidectomy, and that's based on a number of factors. So I just wanted to talk about thyroid isotope scans. So we use thyroid isotope scans less and less. It used to be routine that patients would get thyroid isotope scans looking for hot nodules and cold nodules, with the cold nodules being an increased risk of malignancy. And they're the ones that you target with needle biopsies. But with high resolution ultrasound, we've moved away from thyroid isotope scanning as far as whether it's a distinguishing factor for nodules that are biopsied or not. So the thyroid isotope scan is really only indicated in patients who have got hypothyroidism. Now you can get a diffuse or an absent pattern, or you can get cold or hot nodules. And just remember that we don't do needle biopsies on hot nodules because they'll almost always come back as Bethesda 3. So that's a 5 to 15% risk of malignancy. So we don't biopsy hot nodules. So in the first one, we're seeing a cold nodule. So that's the one that traditionally would be biopsied because there's a slightly increased risk of malignancy. With Graves' disease, you see a diffuse uptake in your thyroid isotope scans. With toxic modular goiter, you'll get a mixed pattern of hot and cold nodules with suppression of the remaining gland. In a toxic adenoma, you'll get a hot nodule with suppression of the remaining thyroid gland. Similarly, with an autonomous nodule, you'll see a hot uptake in the autonomous nodule with suppression of the remaining gland. And in thyroiditis, you won't get any uptake at all. So that's a useful one for thyroiditis. CT, MRI scans, and PET scans have got indications that are probably more in keeping with what we would do, but certainly we would want to know anyone that has a retroexternal thyroid about the extent of it, because sometimes you can see patients with very large retroexternal extension into the mediastinum, and the ultrasound can't pick up the lower extent of this because they can't see through the bone of the chest wall. CT scans are very useful in assessing local cancer spread. So in this patient with a thyroid cancer with invasion of the trachea, which won't be picked up on an ultrasound, we'd certainly be wanting to know that before we did any surgery. Regional lymph node assessment is probably best done by ultrasound, to be honest, but ultrasound has less value in the central compartment. It's much better in the lateral compartment, so that's in the side of the neck as opposed to the central compartment of the neck. Certainly imaging for distant metastatic spread. So with thyroid cancer, we'd be particularly interested in the chest. PET CT scan can show hot nodules in the thyroid. So we commonly see, in fact, I saw a lady today who had ovarian cancer treated last year at Lifehouse, who had a staging PET CT scan that demonstrated a hot nodule in her thyroid. So she's gone through her ovarian cancer treatment and has come to me today with her hot nodule on her PET CT scan, which we're currently working up to see whether it's actually something sinister or something that can be just left alone. Traditionally, there was concern about giving intravenous contrast with patients who have got thyroid cancer, but we would far prefer to have the additional benefit of the soft tissue detail with IV contrast than worrying about any iodine and its potential effects with adjuvant radioactive iodine. And as a general rule of thumb, most patients don't get radioactive iodine for somewhere between 6 to 8 weeks after surgery, and by then the iodine has been excreted anyway. So with thyroid nodules, just when to refer. So certainly if you see any patient that has got a suspected or confirmed malignancy, so if you're getting that report that shows that the patient has got a suspicious nodule, then organise a needle biopsy and then think about referring that patient on for definitive treatment. Any patient that has got obstructive symptoms should be considered for surgery. Toxic nodules, plus or minus in the setting of multinodular goiter, and I'll talk to you about whether you send that to the endocrinologist or the surgeon a little bit later. Certainly anyone who's got significant retroexternal extension, so a little bit of retroexternal extension is not really much of a worry, to be honest, but if you're getting significant retroexternal extension, certainly below the clavicular heads and below the manubrium, they're the sort of patients that we would start discussing about surgery before it tracks too deep into the mediastinum. So moving on to hypothyroidism. So thyroid toxicosis is relatively common in the Australian population. It can be clinical, subclinical, it can be overt, and the incidence increases with age. So the common etiologies that need to be thought about with hypothyroidism are Graves' disease, toxic nodules, exogenous thyroid hormone, painless sporadic thyroiditis or Hashimoto's, painful subacute thyroiditis, and amiodarone-induced thyroiditis. And I'll talk about the more important ones in the subsequent slides. The clinical symptoms and signs are the sort of stuff that you guys know back the front. But the more important ones for the symptoms are the nervousness, the heat intolerance, palpitations, fatigue, and weight loss. And the more important signs are things like agitation, sinus tachycardia, a tremor, and hyperreflexia. So Graves' disease is due to a TSH receptor antibody which increases thyroid hormone production and then causes thyroid gland hyperplasia. It occurs in females to males in a ratio of 5 to 10. The peak onset is between 40 and 60 years. It's characterized by diffuse and symmetrical enlargement of the goiter as opposed to multinodular goiter, which can be quite asymmetrical. If it's been there for a while and can be associated with Graves' ophthalmopathy, which is that thyroid stare, and it can be associated with other autoimmune diseases. A thyroid isotope scan in this patient will demonstrate elevated and diffuse uptake pattern, which is what we're demonstrating here with this diffuse uptake of thyroid isotope. The lab test results will show elevation in the TRAB or the TSH receptor antibody, and the thyroid peroxidase antibody is often elevated as well. The medical treatment depends on the severity of their symptoms, but certainly for, frankly, thyrotoxic patients, beta blockers for symptomatic relief, and then anti-thyroid drugs such as neomercazole and PTU are commonly prescribed. As far as definitive treatment goes in patients who have got relapsing Graves' disease or medically resistant or elevated TRAB levels, surgery or radioactive iodine is considered. Surgery is generally preferred over radioactive iodine in the setting of a patient who's got a very large goiter. Certainly if a patient is considering getting pregnant in the next 12 months, if the patient has got significant eye disease that's present, or if the patient has got any suspicious nodules on ultrasound, those patients will tend to be referred for surgical management of their Graves' disease as opposed to radioactive iodine. Toxic nodules are due to the autonomous nodule in the thyroid that produces excessive thyroid hormone, more commonly in females than males. In the setting of a toxic multinodular goiter, the onset is usually more than 50 years with a goiter that has been present for many years. A toxic adenoma occurs in a slightly younger population group and has been characterized as slowly growing solitary thyroid nodule. The isotope scan in this setting will demonstrate the hot uptake in the autonomous nodule with suppression of the remaining thyroid gland, as demonstrated in this thyroid isotope scan. The lab tests will the thyroid peroxidase antibodies will typically be low or absent. With definitive treatment, remission is rare without definitive treatment, so anti-thyroid drugs to control the medical medical symptoms. Generally, radioactive iodine is better for solitary nodules, but surgery is considered in patients who have got toxic nodules in the presence of compressive symptoms, particularly large multinodular goiter, if there's any concern regarding thyroid cancer, and in the setting of hypothyroidism, in which they're going to get surgery for that anyway, then surgery is certainly considered for toxic nodules. So this is one of my patients who is a 73-year-old lady. She presents with a toxic multinodular goiter. She's having increasing enlargement of the goiter over a period of monitoring over years. She's now developing compressive symptoms and describes feeling short of breath when she lies flat. And certainly the compressive symptoms are more relevant for the thyroid if they're present when the patient is lying flat as opposed to when they're upright. She's been treated long-term on neomercazole, 10 milligrams daily. She has had an ultrasound which has demonstrated marked enlargement of both the right and the left lobe of the thyroid. She has 10 nodules up to 45 millimeters in size. Previous biopsy of the non-toxic nodules has been reported as benign. She's had a thyroid isotope scan which demonstrates 2 functioning nodules, and the CT scan that demonstrates a large multinodular goiter with the presence of retrosternal extension to the level of the aortic arch. And she's also got severe tracheal compression with a tracheal diameter of 5 millimeters, with normal would be up to 10 to 12 millimeters. Her thyroid function tests on neomercazole are well controlled, which is nice for us when we're considering surgery in this lady. And in fact, this lady is a good candidate for surgery as opposed to radioactive iodine. It'll treat her goiter, it'll treat her compressive symptoms, it'll treat her thyrotoxicosis, and she underwent surgery and did very well. Painless sporadic thyroiditis or Hashimoto's thyroiditis is due to autoimmune destruction of the thyroid, more common in females as you'd expect. A peak age of incidence in the 30 to 40 year age group, characterized by a diffuse small goiter, has two patterns. It has the initial pattern of thyroid toxicosis, which occurs over a period of 1 to 2 months, and then with the burnout of the thyroid, development of hypothyroidism, which can be permanent in up to 20%. In these patients, the thyroid isotope scan demonstrates absent uptake. The lab results are diagnostic for Hashimoto's with a markedly elevated thyroid peroxidase antibodies, but with the presence of a normal ESR. Treatment in the hyperthyroid or thyrotoxicosis phase is with beta blockers, and in the hyperthyroid phase, these patients may require a thyroxine replacement. Compared with subacute painful thyroiditis, the pathogenesis is considered to be possibly viral in origin. It's characterized by autoimmune destruction of the thyroid, typically presents more commonly in females over a wide range of years from 20 to 60 years of age, can occur in association with an upper respiratory tract infection, and is associated clinically with quite a tender thyroid. These patients have got thyrotoxicosis that is often present for 1 to 2 months before it settles, often followed by hypothyroidism for the next 4 to 6 months, and in a small percentage of patients can become permanent. In these patients, the thyroid isotope scan once again demonstrates absent uptake, but in contrast to Hashimoto's, the thyroid peroxidase antibody level is low or absent, but they have an elevated ESR. Treatment in the hyperthyroid phase is with beta blockers, and for the pain, generally non-steroidal anti-inflammatory drugs are adequate, but in certain situations, in patients who have got significant tenderness, a course of prednisolone or glucocorticoid is indicated. If the patient goes on to develop hypothyroidism, then thyroid hormone replacement with thyroxine is indicated. So in your patient who has hypothyroidism and you're wondering who to refer to, the referral process is either to an endocrinologist or a surgeon. And this also goes for thyroid nodule management. Now, thyroid nodules can be referred to either an endocrinologist or a surgeon. Both specialties will be happy to look after patients who need further assessment of the thyroid nodules. If the patient has more of a medical condition, such as hypothyroidism or hypothyroidism, they're probably best going to an endocrinologist because surgeons aren't trained in medical management of hypothyroidism. And certainly, if you think your patient is going to be a good candidate for radioactive iodine, so for instance, that patient who's got Graves' disease, that patient who's got a solitary toxic adenoma, then referral to an endocrinologist would be appropriate. Surgeons, the referral process is probably more in the setting of patients who have got symptomatic thyroid nodules, large goiters, etc. Patients who've got any suspicion of cancer, and certainly if patients that are not good candidates for definitive treatment for hypothyroidism with radioactive iodine or don't want radioactive iodine, then referral directly to a surgeon is appropriate in that setting. So for the last part, hyperparathyroidism. So looking at the causes of hyperparathyroidism, a little bit about parathyroid physiology and anatomy so we can understand it, what are the relevant investigations, and just talk very briefly about surgery. So this is a very typical case, a lady who presents with a 53-year-old female who presents with incidentally discovered hypercalcemia. And I think almost universally, the patients that I see have had blood tests demonstrating hypercalcemia that have then been further investigated and found to have hyperparathyroidism. So the hypercalcemia prompted the further investigation with a PTH. So now patients got elevated PTH and hypercalcemia. Clinically, I think the most relevant clinical sign for these patients is lethargy. Everyone knows about stones, bones, moans, and groans. So this patient does not have a history of kidney stones, there's never been a history of pancreatitis, doesn't report any bone discomfort, abdominal discomfort, constipation, or depression. So these are the patient's bloods, and this is fairly typical to what we see. A patient who's been sequentially monitored for some time, who's had elevation of the calcium. We look particularly at the corrected calcium, importantly looking at their renal function as well. Now, this patient has then had a parathyroid hormone done. The parathyroid hormone level is 17 with the upper reference range is 6.9. What's really important is anyone who's got hyperparathyroidism, you want to do a vitamin D. This patient's dropped below the reference range, but secondary hyperparathyroidism may be due to vitamin D deficiency. So this patient then goes on and has further investigations, has an ultrasound. I mainly do ultrasounds in patients with hyperparathyroidism, looking for coexisting thyroid pathology, because the last thing you want to do is take out a parathyroid adenoma only to have to go back because there's some other indications such as thyroid cancer or nodule assessment. Bone mineral density, 3 sites: femur, lumbar spine, and hip. Looking for osteoporosis, because osteoporosis is an indication. This lady's got osteopenia in the radius. This is a parathyroid cystomebi scan, which basically is a low resolution CT scan with a cystomebi technetium scan, and that demonstrates that this patient is highly likely to have a right parathyroid adenoma. And that's what was found on surgery. Had surgery successfully cured with minimally invasive parathyroid surgery because we knew where to go, and that patient has done very well. So just very sort of categorically about the types of hyperparathyroidism, divided into primary, secondary, and tertiary. So primary hyperparathyroidism, the cause is generally unknown. This is in the setting of adenomas and hyperplasia characterized by high calcium and PTH. With secondary hyperparathyroidism associated with patients with renal disease, gut malabsorption, things like vitamin D deficiency, characterized by low or normal calcium but a high PTH. And once the parathyroid glands become autonomous, they develop tertiary hyperparathyroidism in the setting of long-established chronic renal failure, and that's characterized by a high calcium and PTH level. So looking at primary hyperparathyroidism, this is a wide geographic variation, probably due to also relevant biochemical screening. So more common in Western societies where there is more biochemical screening. Incidence about 2 to 3 per 100,000 in females and 1 per 100,000 in males. The incidence increases in age, 2% at 55 years. The vast majority of cases of primary hyperparathyroidism are due to a parathyroid adenoma. There's a smaller percentage of patients who actually have double adenomas. Parathyroid hyperplasia occurs in a smaller percentage of patients, so that can be one or more of the glands showing hyperplasia. Parathyroid carcinoma is exceedingly rare. I've only seen one case of it, and that's generally characterized by very high calcium and very high PTH levels. Primary hyperparathyroidism can be associated with other syndromes such as MEN syndrome, familial hyperparathyroidism, and there's a condition called familial hypocalciuric hypercalcemia, or FHH, which is characterized by patients who've got hypercalcemia, but they've got low levels of calcium in the urine. In patients who've got primary hyperparathyroidism due to a parathyroid adenoma or hyperplasia, you will tend to find that they have got a very high calcium excretion because it overwhelms the capacity of the kidneys. It's important to establish this diagnosis of FHH because these patients are never cured with surgery. So the parathyroid glands can be a bit tricky. Most people have got 4, but some people have got more than 4, and some people have got less than 4. And they can be found anywhere from the mandible to the pericardium. So sometimes as head and neck surgeons, we will never find it because it'll be in the mediastinum. The superior gland is more constant location near the cricothyroid joint, and the lower gland is highly variable in its location. Generally, they're described as being about the size of a grain of rice and the weigh about that should be 40 milligrams. The tricky about parathyroid glands is they have a yellowy brown appearance, and the fat that's all around the thyroid has got a yellow appearance. Sometimes these parathyroid glands can only be seen when you tease the fat out from around the parathyroid glands, so they can be quite tricky to find. Certainly, there's patients who've got parathyroid glands that are only ever found in the thyroid, so intrathyroidal cases, and they can be behind the esophagus, behind the carotid artery and the carotid sheath. They can be anywhere. So if we look a little bit about the parathyroid physiology, so the parathyroid glands secrete PTH. Now that has an effect on the bone, which stimulates osteoclastic activity, which causes bone resorption and release of calcium into the bloodstream. And when that occurs over a very long period of time, the patients develop osteopenia and then develop osteoporosis. In the kidney, the parathyroid hormone stimulates reabsorption of the calcium from the urine with excretion of phosphates and also causes activation of vitamin D, which then acts on the small intestine. And in the small intestine, the vitamin D causes increased absorption of calcium from the diet. The net result of this is that there's increase in serum calcium, and there's a feedback loop back to the parathyroid glands to switch off parathyroid hormone function if the serum calcium is elevated. And this is not the case in parathyroid adenoma, where you get increased secretion of PTH despite negative feedback. So the clinical features, I think the most important one and the most consistent one is lethargy in patients. You need to ask about muscle and bone pain, abdominal cramps. Kidney stone disease is important because that's an absolute indication for surgery, and patients also may present with depression. There's also evidence that PTH is a negative inotrope on the heart, and so it can cause issues with heart contractility. The vast majority of patients actually present with asymptomatic hypocalcemia and hyperparathyroidism, and is usually an incidental finding on routine blood tests. Specifically for hyperparathyroidism, you want to know about their renal function, their corrected calcium, the phosphate levels, magnesium and alkaline phosphatase, which can be an indicator of bone turnover. If you're worried about, how important or how significant the elevated calcium is, and iodine calcium is a bit more specific. In the setting of looking at PTH, you always need to do a vitamin D, because vitamin D deficiency is a cause of secondary hyperparathyroidism. So your hyperparathyroidism may be corrected simply by replacement of adequate vitamin D. 24-hour urine collection, looking at calcium excretion and creatinine excretion, and you work out the calcium excretion to creatinine excretion ratio, and if it's very low, so those patients who've got a very low calcium excretion in the urine, you need to consider about this condition called FHH, which is caused by a mutation in the calcium sensing receptor gene, and that's if the ratio is less than 0.2. Okay, so those patients, they never get an operation because they're never cured with their hyperparathyroidism, because they don't have a primary parathyroid abnormality. The most important radiological investigations are the sestamibi scan and the ultrasound. The issue is that about 10 to 15% of patients will have a negative sestamibi scan in the setting of primary hyperparathyroidism. The ultrasound is useful mainly for the thyroid assessment. They may see the parathyroid gland, but I have had numerous situations where there's been very big parathyroid glands that have not been seen on the ultrasound, and that's because they tend to tuck in around the trachea, and the ultrasound is not good at looking at structures around the trachea. In the setting of a patient who's got primary hyperparathyroidism and a negative sestamibi scan, the next test to organise is a 4D CT scan, or on the request form you put parathyroid CT scan. It's 4D because there's 4 phases that are used for the scanning, and it's very useful in those patients with negative sestamibi scan, because if it identifies the abnormal parathyroid gland, then you can then offer that patient focal or localized surgery as opposed to a 4-gland exploration. Bone mineral density is important for the assessment of bone status to see whether the patient has established osteoporosis. And after surgery, you can expect a 10 to 15% increase in bone mineral density 12 months after surgery. So this is just an example of a parathyroid CT scan. So in this setting of a patient with a negative sestamibi scan, there's a parathyroid adenoma in the right paratracheal groove. So this patient, once it's established that that's where the problem is, they can then be offered localized or minimally invasive surgery. There have been guidelines published about surgery in asymptomatic primary hyperparathyroidism, and consider referring patients who meet one or more of these guidelines. So if they have a serum calcium of 1.0 milligrams per deciliter, or for us that's greater than 0.25 millimoles or greater than sorry, that's supposed to be up there. So it's greater than 2.5 millimoles above the reference range. So that's around about 2.8. 24-hour urine calcium used to be an indication for referral for surgery, but it's not currently. Anyone who's got renal impairment, anyone who's got established osteoporosis with a T-score of less than negative 2.5, or history of previous fracture. Consider referring patients for surgery under the age of 50 years of age. Otherwise, you'll be monitoring these patients for years. So for premenopausal women or men less than 40 years of age, Z scores rather than T scores are used. Okay. So this is just an example of minimally invasive parathyroidectomy. So essentially, in a patient who's got a localized parathyroid adenoma, we can offer them localized minimally invasive surgery through a 3 to 4 centimeter incision directly over where the parathyroid abnormal gland is located, using a small incision getting down onto the parathyroid adenoma, removing the parathyroid adenoma, and then closing the wound, single Steri-strip. And I'm now doing these as day surgical cases. We tend to we do them first thing in the morning. We check their PTH test about an hour or two after the surgery, and we're looking for a greater than 50% drop in their preoperative PTH. So a lot of these cases can now be done as day surgery. That was my last slides, and so I'm very happy to take questions.
Okay, thanks very much, Michael, for a great presentation. And we do have some questions. The first question that I'll put to you comes from Sugan Ramakrishna. And the question is, regarding subclinical hyperthyroidism, how long do we keep monitoring an asymptomatic patient before initiating treatment? I know that I get reports from my pathologist saying subclinical hyperthyroidism suggests follow up in a month, or it's usually a month. How long do we keep doing that?
I actually sent an email to Ash about this because I thought this question might come up, because we don't see in the surgical setting, we don't see subclinical hypothyroidism. It's something that the endocrinologists see as far as management goes. Ash, are you still there?
Yeah, I'm still here.
Did you want to answer that?
Yeah, so a couple of things with subclinical hyperthyroidism. So when we get referred these people, I always try and dig out as much pathology as I can find. So sometimes you can track people over 5, 10 plus years and find that their TSH has always been 0.2, 0.3, and that's probably just their normal physiological set point, in which case you can reassure everyone that nothing needs to be done. African Americans can have a TSH that sits slightly below normal reference range. And if there's actually, true thyroid autonomy, so an early nodule, if the TSH sits between 0.1 and 0.5, for someone under 65, there's no indication to treat unless someone's got comorbidities such as osteoporosis or cardiac arrhythmia. Certainly once the TSH drops below 0.1, there's a medical indication to treat. How long do you monitor these people for? Look, it's probably reasonable to just tag it on as part of the annual pathology test. But if you're tracking someone who's younger and you've reassured yourself that nothing's changed over years, you can probably assume that that's just their normal physiological set point and not have to do scintigraphy.
Okay, thanks, Ash. We have a series of questions from Asha Osawa. The first is, and I know what my radiologist does, they just do it automatically, but the question is, should we ask for a TIRAD score when we request thyroid ultrasound?
I guess it depends on whether you know whether that radiology practice is going to give you that. So in fact, I actually saw a lady from out of area and I wrote on the form, for the report to be given as a TIRADS report, because I find it very kind of frustrating when you get a report that basically just gives you very limited information, such as the size of the nodule, and that's basically it, because that doesn't really give you the important information that you require. So yes, and that's, I mean, if you know the radiology practice and you know they're going to give you that information, then you don't need to. But if you don't know them, then I actually do that. I put that on the form. Can you give the report as TIRADS? Otherwise, you just it's in some respects it can be a fairly meaningless report unless you're confident in reading and interpreting ultrasounds of the thyroid.
Yeah, I must say, which I never am. Another question from Asher is, excuse me, is thyroid ultrasound operator dependent in defining nodules, or can it be done at any radiology practice? Now, I'm sure that you have your favourite radiologist. Should we have one as well, or can we send them to any reputable radiologist, knowing that they'll do the job?
I think it's highly variable, to be honest. Certainly, I've got my preferred ultrasound providers, and I will refer to one or two of them because I know them, I know the quality of the reports, and I know they're reliable. I think I judge the quality of the reports based on two things. One, when I look at the images, if they're really grainy, hard to visualize, what's going on, then I think they're using poor quality machines, and probably the reporting is going to reflect that. I think if you're also getting poor quality reporting, then I think that's a bit of a sign that you should be going somewhere else.
Another question for Asher is, what is the normal size of thyroid lobes? In other words, when do we start to say that this thyroid is indeed enlarged? I
think probably the better thing to do is look at the volume. So so a normal volume, sort of 6, 7, 8, 9 mils, that's fine. Look, I think the reality is that thyroid goiter is probably not really that important until it's around 20 mils. So you generally, I see people all the time who have got, nodules in their thyroid, and they're wondering whether their thyroid complaint is related to that. So it's pretty hard to say a thyroid gland that's 10, 12 mils with a 2 centimeter nodule is going to be the cause of anything at all. So certainly, I don't think any thyroid glands under 20 mils are really that that big at all.
Okay. We have
Can I add something there?
Yes.
Sorry. Yeah. So generally, in my head, each lobe, I generally would say 4 to 10 mils is normal, and isthmus normal thickness is up to 2 millimeter. And if you're looking at the longitudinal, so supero inferior, the normal length of a thyroid lobe is about 4 to 6 centimeters. So they're just some, normal anatomical sort of description.
Yeah, I think the volumes is probably the easy one to interpret.
A question from Victor Yang is, how often and how long do we need to monitor benign thyroid nodules, i.e. TIRADS score less than 2 on ultrasound? Yeah, so the guidelines that I follow is if I'm seeing them first time for their first ultrasound, then I do an ultrasound in 1 year. If there's no change, 3 years. If there's no change, 5 years. Okay, thank you. A question from Sarah Lynn. Is CT mapping or robotic surgery being used in thyroid surgery to help locate parathyroid glands? There are various tools you can use. When I first started doing some parathyroids, I was using this gamma probe. The problem is that it can be misleading because it was technically a little bit difficult anyway, but the patient gets a preoperative injection of technetium and you use this gamma probe, but the heart takes it up as well, so you can end up getting a tracer reading that's going down towards the mediastinum, but it's a false reading. Look, to be perfectly honest, I think with the imaging that you currently got, I actually don't see there's any role for anything more than your preoperative ultrasound, Cestum EB scan, 4D CT scan if you can't see it on Cestum EB or ultrasound, and then just find a good surgeon. We don't do robotic surgery in parathyroid. It's kind of, why would you do a robot when you can do a 2 centimeter, well, about a 3 centimeter incision? It doesn't really have a role. There are very, very few people doing robotic thyroid surgery.
because the vast majority of people who are doing robotic thyroid surgery around the world were the Koreans, and there's a real question as to why you should be doing robotic thyroid surgery for small cancers anyway, when we're moving into a new phase of active surveillance of even patients who've got cancers up to 10 to 15 millimeters. So robotic thyroid surgery is probably on its way out in some respects. It's useful for people who have got cultural things like they don't like the scar on the neck.
Okay, look, we are getting close. Well, we are over time, so I'll make this the last question, and it's from Morling Lee. What is the definite indication for surgery on the parathyroid adenoma?
The definite is things like presence of kidney stones, pancreatitis. But look, I think the reality is in my discussion with patients, if you've got a patient who's got hypocalcemia, hyperparathyroidism, they've got localizing studies, you know where you need to go, then that's a patient who you just say, look, we can do a 1-hour operation, we can cure your problem, you don't need to be monitored, it's going to be good for your bones. And I think that's the sort of patient who's a really, really good candidate for surgery. I think the difficult ones are the ones who have got kind of calciums at around 2.65, 2.7, who have got non-localizing studies, no evidence of bone disease. They're the ones that I think, you know, we should be avoiding surgery on, because those patients, you've got to commit to a 4-gland exploration, which could be not 1 hour of surgery, but could be 4 or 5 hours.